Good evening, everybody. Thank you for joining us for this SECEC webinar. So tonight it's not a birthday celebration with lots of balloons. It's a serious talk about subacromial balloons. So subacromial balloons have been on the market for the last 10 years, but they have gained renewed public attention in maybe the last 2 years, especially since Stryker boat in space. But maybe even more so since there were two very high-level trials which were published last year. So today we have many different treatments for massive irreparable rotator cuff tears, whether it's a reverse shoulder arthroplasty, partial repairs, biceps tenotomy, SCR transfers, or balloons. So this may suggest that we have not found the holy grail yet for this pathology, or that there are different subsets of pathologies or patients who may benefit from this specific treatment. And this is, in my opinion, the problem with today's scientific literature. It is riddled with an ever-expanding amount of data, and it's hard for readers, simple readers such as me at least, to make sense out of it. So we have meta-analysis on one hand to try to serve us to make sense of it, but they tend to serve us some blurred, non-contributive conclusions, and it's maybe we lose all the subtle evidence with this kind of publications. So we need high-level evidence studies, and I salute both groups that have published their level 1 trial about subacromial balloons, so in the JBGS and the Lancet trials respectively. So at a glance, it looks like we have two trials about the same problem and who give two opposite results. But are we really comparing apples and apples, or is it apples and pears? Who is wrong, who's right? Is this really the question? So for this, it's important to gather as a scientific community, and I really thank all the participants for this webinar to be here tonight. I have the honor to introduce first Nikhil Verma from Chicago, who's here and who will present us the trial results of the JBGS study. And then we have Andy, Metcaffe, and Steve Drew from the UK, who will present their results of the Lancet trial. And then I have asked Ofer Levy to just give us his general thoughts on bias, because this has nothing to do with tonight's results, but there is bias today, and we have to be aware of it, whether it's on the side of the industry, of course, but on the other hand, we also have insurance companies or governments who are trying to reduce the healthcare expenditures, and they also have an incentive to reimburse less. So maybe less is more, or more or less, who knows? So tonight we have to answer the question about, is there still space for in space? And to conclude, we have Davide Cucchi from Germany, who will just wrap it up and try to summarize and make a bit of sense of what we said tonight. So thank you everybody for being here, and thank you Sylvie Noël and all the organizing committee for this great event. So we can try to start with Nikhil, who will give us his first talk.
Greg, I appreciate the invitation to speak today. It's obviously a little bit earlier here in the United States than it is in Europe, and so we're in our workday, which is why I'm wearing scrubs at this time. But I really appreciate the opportunity to take some time out to discuss what I think is a really valuable topic. Can you, is the screen share showing up appropriately?
Perfect.
Great. So I'm going to present the results of the US/North American trial regarding the subacromial balloon spacer and the management of massive rotator cuff tears. As you heard, my name is Nikhil Verma. I'm from Rush University Medical Center in Chicago, and probably not the best time to visit in January, but if you do make your way to Chicago, we'd love to host you at Rush. One of my disclosures is that I do serve as a consultant for Stryker and was serving as a consultant as the lead on this clinical trial. So I think we're all familiar with the problem, and Greg hit on it during the introduction, which is we all see these patients with massive irreparable rotator cuff tears, which may be either mechanically irreparable or at times biologically irreparable. And the question is, what are the proper treatment algorithms in order to determine how to manage these patients. We know how these tears are defined. They're large, they're greater than 2 tendons, and they often have associated fatty infiltration or atrophy. And there are a number of different treatment options available. In some cases, we can perform primary or partial repairs. We can augment those with grafts or use interposition grafts. We've heard about the superior capsule reconstruction, tendon transfer, reverse arthroplasty, and in the last 10 years, of course, the balloon interposition has been demonstrating controversy throughout the literature in terms of what is its role for management of these patients. I think at the end of the day, regardless of what treatment option we're using, we all think about some of the basic biomechanical principles: humeral head depression, concavity compression, reestablishing the ability to achieve deltoid elevation. But at the end of the day, what our patients are really most interested in is pain relief. And if we can achieve pain relief and we can accelerate their recovery and rehabilitation time in comparison to some of the other procedures that I've talked about, that certainly is a big advantage to the patient population that we manage. So I think when we think about the considerations for who may be a candidate for balloon, we really need to think about this more broadly in terms of who is a candidate for soft tissue surgery alone. And the Hamada classification has been very helpful in my hands in terms of determining which patients may benefit from soft tissue-based procedures. These are patients that are primary or revision surgery without arthritis. They have maintenance of pre-op elevation, generally better than 90 degrees, or in fact, full elevation. They prioritize pain over function recovery. And by that, I mean strength recovery. And we should always keep in mind the age of the patient, the cost of the procedure, the complications, and what are our potential revision options if that may fail. So in general, we're talking about patients that fit into the grade 1 or 2 classification from Hamada. Grade 3 starts to give us significant pause, and patients beyond that generally are not applicable for these types of interventions. So the question is, why would you use the balloon? Well, I think the basis is it's a simplified surgical technique for the surgeon side, and it's a very accelerated rehabilitation with earlier clinical improvement for the patient side, which results in improved patient satisfaction, particularly at the group that we're targeting here. How does it work? Well, that's the million-dollar question, right? I think we all looked at this in the beginning and said it just not going to work. That's not going to have a chance. But when we look at some of the biomechanical data, we do know that it can reduce pressure within the subacromial space, and we also know that it can provide humeral head depression. But the reality is that it goes away. And so the question is, how do we continue to see improvement once the balloon has entered its resorption phase? And I think the best way that I think about this is, if you think about these patients, the vast majority of them have been asymptomatic but well-compensated patients for a long period of time. These rotator cuffs are not new, but something has happened that's tipped them over into a decompensated world. And so like a cortisone injection, if we can render them asymptomatic, allow them a period of rehabilitation for deltoid reactivation, we can achieve pain relief, we can facilitate rehabilitation and achieve a good clinical outcome, even once the balloon is gone. The procedure itself is relatively simple. We debride, we take down any osteophytes, we remove the biceps if necessary. We do a subacromial smoothing. We confirm that the subscapularis is intact. And then the balloon deployment is literally as simple as you see here, which is simple inflation within the subacromial space, taking on average about 2 to 3 minutes. So the big question, of course, is, does it work? And this was the basis of the initiation of the US clinical trial. There is some early data from Europe that would suggest some about 80% improvement in patient-reported outcomes, sustained benefit, and no serious safety risk. But these were all small clinical case series with no comparative groups. The purpose of this study was really to evaluate the safety and the efficacy of the device when used for massive rotator cuff tears. I'd be remiss without mentioning the number of authors, over 30, that were involved in this clinical trial. If you're going to do a trial on this scale or similar to the trial that was done by Andy and others, you really have to have buy-in of a number of different surgeons and support teams that help you to complete this type of work. It's really a very, very large undertaking. The study design is prospective, it's multi-center, 20 sites throughout North America, randomized, two-arm, blinded to the patient, unblinded to the surgeon, comparing in-space to partial repair. The methods were really randomization in a one-to-one fashion. We recorded things like the operative time, how long it took to put in the balloon, how many anchors we used. Follow-up was at typical timeframes up to 2 years. We collected the standard battery of patient-reported outcomes, and we used MRI to assess the device location at an early time point. We decided that we needed a primary outcome of ASES, and this was used to evaluate change from baseline. And we basically translated our results into clinically significant differences using the MCID and SCB, as well as PASS scores that have been previously established by our group and others for rotator cuff surgery in this patient population. The patient criteria, this is where I think really the meat and potatoes, or in America, as we say, the rubber hits the road. The inclusion criteria was older patients greater than 40. The average age of our patients was over 60. These were full thickness, massive posterior superior rotator cuff tears. They were all painful and failed a conservative approach, which for the vast majority of our patients include injections, anti-inflammatories, and physical therapy. They had to have a functional deltoid, and they were not stiff. They had preserved range of motion. We excluded patients that were greater than Hamada 2 with severe arthritis, those with subscapularis tears, and those were any tears that the surgeon deemed to require a repair or were irreparable. If they had deltoid deficiency, a joint trauma or infection, or if their tears were felt to be functionally repairable at the time of surgery. We didn't need to rehabilitate in a standardized fashion to protect the blinding of the study, so both groups were immobilized between weeks 1 and 4 with passive range of motion. We weaned from the sling with traditional progression to active range of motion at week 4 to 6, and then we initiated strengthening at about weeks 12 to 14, and that was standard between the two groups. We had nearly 200 patients, 93 in the balloon group, 91 in the partial repair group. As I said, this was an older age population, 66 was the mean age, and these were chronic tears with long durations of symptoms. The groups were very similar in baselines with no statistically significant difference between demographics, and we had a very high patient retention rate of 88%. As you would expect for this type of population, there were a number of different procedures that were performed within the groups, biceps procedures, debridements, distal clavicles, decompressions, but there were no differences between the procedures performed or the number of concomitant procedures performed between the two groups themselves. The results, so we had a very high rate of patient retention up to 88%, which leads to a favorable analysis. This is what it looks like when we look at MCID and SCB and PASS. So this is the percentage of patients that met each of these criteria. It was about 80% in both groups for MCID, about 80% in both groups at 2 years for SCB, and about 50% for patient acceptable symptom state. So in my opinion, these are very robust and favorable results for both groups with a very challenging patient population. There were no differences between the groups at 6 weeks, 12 months, and 24 months. When we looked at range of motion, the range of motion was significantly higher in the balloon group, but before 6 months, the range of motion was significantly higher in the balloon group after a year. No differences in 2 years. And I think this watershed plot that you see on the top right of your screen is the most helpful. The zero axis is patients that had no change in range of motion. Below the zero axis are patients that lost motion. Above the zero axis are patients that gained motion. So what you see is that there are very few patients that lost motion, but in those patients that lost motion, the reparative group lost more motion in comparison to the balloon group. And in the group that gained motion, the balloon group gained more motion than the reparative group. So it was a very range of motion friendly operation. Here are some of the other clinical outcomes: the WORAC score, the constant score, the VAS score, the EQ5DL scores. Some benefits of the balloon early on, but overall, no significance between either of the groups at any of the time points that we tested. The operative time, of course, as you would expect, was markedly different. The average operative time for the partial repair group, 71 minutes, versus 44 minutes for the operative group and 4 minutes for insertion. And keep in mind that the patients had to be randomized intraoperatively. That is, once we saw that patients met a criteria, the study team would have to leave the room, perform the randomization algorithm. And so in my experience, the total procedure time for balloon patients is less than 30 minutes. The complications, of course, we're all worried about untoward effects with this. We saw no complications in either group and none that were related to the device itself. When we found reoperations, we had 1 scope and 2 reverses in the partial repair group, 1 scope and 2 reverses in the balloon group. 1 patient did have a reverse in the balloon group after they fell and sustained a proximal humeral fracture. But again, we're talking about 3 additional surgeries out of 90 in each group, which is very favorable for both groups, given the challenging patient population that we're talking about. So in summary, we found comparable or better outcomes to partial repair at 2 years. We found earlier benefits, particularly with regard to range of motion and pain improvement scales in the balloon group compared to the partial repair group. And we saw success without sacrificing range of motion in a procedure that was markedly easier for the surgeon and faster in terms of the time that it takes to proceed. So this is an example of one of my cases, a 67-year-old male, shoulder pain for several years. He's had cortisone injections and physical therapy. The goal was to increase function. You can see a very large rotator cuff tear with retraction beyond the level of the glenoid. Certainly biologically probably irreparable and mechanically probably irreparable. And this is his 2-year follow-up visit with preserved range of motion and maintaining a pain-free lifestyle. So where do I think the balloon rises? I think the advantages are a minimal pain with the procedure, rapid post-op pain relief with minimal range of motion or therapy requirements. Functionally is generally maintained, although I do tell patients that we should not expect drastic improvements in strength recovery. They do remain, and there are no significant complications or significant risks, in our opinion, with regard to the balloon itself. Where does it fit in? Well, I think it's primarily those older patients with maintenance of the articular surface who have maintenance of elevation and are prioritizing pain over strength recovery. These are the sweet spot patients that are indicated for this procedure. They're older, they're lower demand, their function is maintained, and they have minimal to absent arthritis. Some remaining questions. What do we do with patients that do have subscapularis dysfunction, but maintenance of function? I'm not sure I know the answer to that. Can we reverse pseudoparalysis? In my opinion, with patients that have less than 90 degrees of elevation, their prognosis is guarded with regard to this procedure. The results have been durable over time. The study has now been published, and the initial patients enrolled over 5 years ago. And finally, what are the implications when putting the balloon on top of a repair? We certainly don't know the answer to that at this time. So with that, I appreciate your attention. Thanks very much.
Thank you very much, Nikhil. So I forgot to tell you before, but you can ask some questions. So on the Q&R menu, if it doesn't work on the chat, and we'll read them out loud later during the discussion. So now we're going to go straight to the next speaker, Steve Drew, who's going to talk to us about the results of the Lancet trial. Thank you, Steve.
Thank you very much for the invitation. So I'm going to present the results of the START Reacts trial, which was a group sequential double-blinded multi-center randomized controlled trial carried out in the UK over the course of 2.5 years. Professor Andrew Metcaffe, who's with me this evening, is the chief investigator. I was the senior surgical investigator, and Gev Babra, who's one of my colleagues, and Tom Lawrence were the 2 other members of the surgical team. This research was funded by a partnership between the Medical Research Council and the National Institute for Health Research, and was essentially funded on the basis of the mechanism and the adaptive trial design. As part of the trial, 23 of the InSpace devices were provided free of charge by Orthospace, and they also funded some of the training costs that we used to actually train the surgeons prior to commencement of this trial. However, the full independence of the trial team is and was protected by legal agreements. In terms of our conflicts of interest, a number of the trial team were members of 2 other studies, the Racer Knee and Racer Hip, for which Stryker is also funding treatment costs. I have an educational contract with Wright Medical, obviously now owned by Stryker, although that's primarily to do with arthroplasty. And in addition to this, a number of the team members sit on the NIHR panels and undertake other activities for the NIHR. So, as Nikhil's already mentioned, it's a common problem. Many treatment options have been postulated, but little evidence base to inform us, what is the best treatment for patients presenting with massive rotator cuff tears, and there's few ideal options. So the in-space balloon, this is a saline-filled biodegradable balloon spacer made from PLA and epsilon caprolactone, which is deployed arthroscopically into the subacromial space. Again, as Nikhil has already mentioned, we don't really understand the mechanism of action, but postulated action is that it reduces friction between the humeral head and the subacromial arch, and therefore improves the mechanics and allows a period of time for the rehabilitation to be effective. So prior to the commencement of this study, it was CE marked in 2010, and 30,000 of these balloons have been implanted throughout Europe. A few more now, obviously, in North America. Initially, there were just a few case series, but now there's 19 published case series. Probably the most well-known is SECEC's study from Croatia. And if you look at their outcome measures, that's the graph on the bottom. With time, following insertion of the in-space balloon, all their outcome measures improve and are maintained. A number of other case series have shown generally the same result. Prior to this starting the trial, we wanted to look at, well, what happens to patients who are enrolled into rotator cuff trials? And we did a systematic review and meta-analysis of 57 trials that have been published on treatment of rotator cuff tears. The top graph is for those undergoing operative treatment, the bottom graph for those undergoing non-operative treatment. And what you can actually see is, regardless of treatment, in general, patients' outcome scores get better with time, whether it's non-operative or operative treatment. And this perhaps should just start to ring a few alarm bells over the use of case series to inform us of new devices. So the National Institute for Health and Clinical Excellence in the UK published their views on the in-space balloon, and we were restricted to using this as in the context of research only in the UK, but they recommended a randomized trial. Perhaps not surprisingly, this was then funded as a call, so the money was put up front. And actually, despite our thoughts that this was funded because shoulder surgery is a really good thing to fund, it was actually funded on the background of what's called the adaptive design. So that's our methodologists and statisticians came up with this design whereby you could tell potentially much earlier in a randomized trial of a new surgical technique or a new surgical device, whether it was effective or not, which potentially would shorten the trial duration and therefore the cost. So our two comparators were a patient having an arthroscopic debridement and biceps tenotomy versus the same procedure, with the only difference being insertion of the in-space balloon. And this was purely to see what added benefit adding the in-space balloon had. So the inclusion criteria, again, should be no surprises. Those patients who were deemed by the clinician to have a irreparable rotator cuff tear, those patients with intrusive symptoms that had failed non-operative treatment. Again, we excluded those patients with significant glenohumeral arthritis, those with subscap deficiency, and we defined that as a tear of more than 1 centimetre of the upper body, or in any patient that was repairable, or in any patient where it was not repaired. Those in whom it was felt that interpositional grafting or tendon transfers were indicated, pseudoparalysis as determined by the treating clinician, unrelated symptomatic disorders of the shoulder on that side, neurological and muscular conditions, proximal humeral fractures, and then essentially a group of patients who were unable, because of age or they couldn't consent, to be entered into the trial. So that's our trial design. So we basically assessed patients for eligibility in shoulder clinics, and if they were willing to participate, they were recruited, consented, and we measured their baseline characteristics. Randomization, again, was performed in theatre on a 1-to-1 basis to either an arthroscopic debridement with biceps tenotomy or an arthroscopic debridement, biceps tenotomy, and insertion of the in-space balloon. Our follow-up points were 3 months, 6 months, and 12 months, and our primary outcome measure was the Oxford Shoulder Score at 12 months. We've also followed the patients for 24 months, and we just finished analysing the 24-month results. So again, as previously mentioned, you need a lot of centres to get these trials performed, 24 hospitals throughout the UK, and all the surgeons that were enrolled were fellowship trained subspeciality shoulder and elbow consultants. Arthroscopic debridement. Prior to this, an diagnostic arthroscopy was performed to assess whether the tear was truly irreparable. A number of studies, a number of patients obviously at this stage were deemed ineligible because they actually had a repairable cuff tear and obviously weren't entered. A biceps stenotomy was performed in all patients if it was not already torn. Arthroscopic debridement then carried out bursectomy in line with the guidelines laid out by InSpace, but we retained the CA ligament. They could perform a subacromial smoothing if indicated, but the CA ligament was retained in all patients. We undertook training of the surgeons prior to this. They had videos and pamphlets given to them. We followed the company guidelines on the insertion of the InSpace balloon. A company rep was present in 85% of the cases carried out in the UK. We also collected arthroscopic photos and we analysed those at the end to check for any potential errors. Rehab, again, same in both groups. Sling for 2 weeks, followed by early movements and essentially an anterior deltoid strengthening program. The adaptive design, a little bit more to say about that. Prior to commencement of this, we said our methodologists and statisticians undertook some trial simulations, and what they were trying to ensure, the boundaries were set so that if enough data was gathered early in the trial, because, and by that I mean the sample size, regardless of the power measurement, already gave a result such that even if it was fully recruited to the power, it would not change the outcome. The trial was essentially stopped at that stage. So again, trial design, it was a blinded study, follow-up points as previously described. By blinding, I mean the patient was unaware. The surgeon obviously at the time of surgery was unaware, but the operation note made no mention of the procedure the patient had had. So it was listed an arthroscopic debridement, biceps stenotomy was mentioned if that was undertook, but it did not actually mention whether the InSpace balloon had been inserted or not. That was kept separately. If it was necessary for that to be released because a patient, subsequently turned up in an emergency department with a problem, that could be gained from us, but that ensured that none of the researchers that were subsequently measuring scores were aware of what the patient had done. And we measured their outcome scores at 3, 6, 12 months and 24. And essentially what we were looking for at all these time points was, had we got enough patients to actually evaluate the trial at an earlier stage? So this is our recruitment graph. You can see this followed our plan until COVID, and then it flatlined. July 2020, our data monitoring committee informed us the trial was stopping because a result was known. And we then had a year where we were totally unaware of the outcome of that. So we knew the trial had said one is either better than the other, or there's no difference. And whether you recruit another 100 patients, it's not going to change the outcome. That stage, we'd randomized 117 patients. Our planned maximum had been 220. Our follow-up at 12 months is 97%. So baseline demographics, there was no statistical significance between the two groups. I will just make a point about our range of movement measurements. We used the method that Chris Constance had described. So we stopped the measurement when it became painful. So if the patient could elevate their arm to 140 degrees, but it became painful at 90, 90 was what was recorded, not 140. So it's the point at which it became painful. Our primary outcome measure, the Oxford shoulder score at 12 months. The orange line is for the debridement only, the green line for debridement and InSpace balloon. And what we showed is the patients who'd had an InSpace balloon device inserted had a mean Oxford shoulder score, which was 4.2 points lower than those with the debridement alone. This is the individual Oxford shoulder scores for plots for each of the patients. What you can probably see, again, the green is the patients who'd had an InSpace balloon inserted. there were more patients whose actually scores got worse with the in-space balloon than a debridement alone. We then did some subgroup analysis. We compared sex, tear size, age, and the acromial-humeral distance to see if this had any impact on our results. And essentially for tear size, age, and acromial-humeral distance, there was no effect on the outcome. However, when we analysed male versus female, what we actually find, there was no difference between the males. However, in general, females had an Oxford shoulder score 11 points on average worse after the in-space balloon device was inserted. All our other secondary outcome measures were heading in the direction of a debridement only group were better, but these were not statistically significant. In terms of our adverse events, we had 3 patients, 2 who had persistent pain, 1 in each group, and 1 patient in the in-space balloon group had to have a reverse shoulder inserted because of persistent pain inside the group. Health economics, QALYs were perhaps not surprisingly in favour of the debridement only group. The costs were $2,060 per patient. And the overall conclusion from a health economics was the device was highly unlikely to be cost effective. There was a less than a 1% chance at a cost of £20,000 per QALY. So, conclusion, we do not recommend the in-space balloon be inserted in patients with irreparable rotator cuff tears. As already been mentioned, however, there may well be a group who benefit, but we don't know which that group is. And we also were not fully aware, whilst obviously females fared worse, is when it should not be used. I think randomized clinical trials are needed when introducing new surgical devices because of the issues around using case series alone, particularly in a condition where the natural history and treatment improves with time anyway. Adaptive trial designs can reduce the time to deliver results, as we've been able to show in our trial design. Further information is available, and both Andy and myself very happy to answer questions, but also field via email any queries you have on the trial. Thank you very much.
Thank you very much, Steve, for this brilliant presentation. So we have high method studies with which are really non-disputable. So you have very different results, of course, but I think you are not comparing the same groups. So Steve, do you think there's still a space for this this procedure? Or
yeah, I mean, there may be. I think the honest answer is we don't know in which patients potentially get the benefit. So there is no doubt in what our results show is that there are a number of females who do really quite badly after the insertion of the in-space balloon. We can't define that group anymore. So, you know, is it a certain, you know, age of females? Is there certain other characteristics that would help us define that group? But there is no doubt is that subgroup of females drag down the results. If you look at the males, obviously there is very little difference between it. Not really enough difference that you could, you know, conclude it was of significant benefit, because there literally was less, I think it was 1 point difference between it. So that's of no clinical significance. But yeah, there may well be a group. I think it's just very difficult to determine the characteristics of that group that it would help in. And with all these, I suppose it's your comparator that makes the difference. What you're comparing it with, and obviously the two trials have used different comparators, and that's why they may well have been given seemingly different results, because our comparators are different.
Absolutely. And just before I let Davide Cucchi ask you a few questions, I just have something that's bothering me is we don't know the mechanism of how it works, the balloons. However, I don't like in my practice using something I don't know how it works. What are the hypotheses? Maybe Nikhil, can you answer this question? The hypothesis behind the mechanism action, and how can we expect long-term results or mid-term results if it's biodegradable?
Yeah, it's a great question, and I would give you two answers. Number one is, despite what we think we may know for procedures like SCR, et cetera, the reality is we don't know what I was saying is, the reality is we don't know the reason why many of these procedures work, right? Why do people get better when a rotator cuff mechanically fails and the pain still improves? Why does an SCR result in improvement, even though a significant amount of them fail and we don't see any difference in acromial-humeral distance? I think what we're learning more and more is that there is a value for interposition in the setting of intact articular cartilage that results in improvement by recentering the humeral head. And lastly, as I pointed out during the talk, we know that there are thousands of these patients that walk around every day with asymptomatic chronic rotator cuff tears that look in large part like the rotator cuff tears that we're treating in both of these trials. So in my opinion, I do think that there's a value in the interposition in order to hit the reset button on the shoulder. And I think if we provide in a period of time of minimally symptomatic or asymptomatic rehab, we can re-educate the deltoid to provide elevation. And these people go back to the world that they lived in for many years before they came to see us, which is a well-compensated chronic rotator cuff tear.
Thanks. Davide?
Thank you, Nikhil. Thank you, Steve. We decided before we give the stage to Ofer Levy for some thoughts about methodology, to ask you a couple of questions which came from the audience regarding the methods of your study. And I picked up 3 of them. The first one is regarding shoulder stiffness. Nikhil, you mentioned in your trial, you excluded patients who had a limitation in passive range of motion. Is it correct? And to Steve, the question if also the same exclusion criteria was applied in your group.
Yes, it's correct. I mean, I think 2 things. Number one is in this age group that you're dealing with, if they have limitations in passive range of motion, that's often suggestive of an underlying degenerative condition, which we know is probably not going to respond well to this trial. But the reality is that what we're looking for here is patients that have maintenance of function, but pain is their primary complaint. And so if you throw stiffness into the equation where they can't lift, even if you eliminate their pain, then I don't think these patients are going to be good candidates for this type of procedure, or frankly, many of the procedures that are offered for soft tissue management of massive rotator cuff tears. Okay,
Steve, how did you deal with patients with reduced passive range of motion?
They were excluded. I mean, stiffness, I think, as Nikhil's already saying, stiffness is bad news. Stiffness, they're not going to do well. So yeah, if they had significant stiffness, they were excluded. Very much following, the process and the guidance given by InSpace for its use in the first place. They don't do well. I think you've got to consider other methods of treatment. Pseudoparalysis is the other interesting one. Again, we excluded it. We didn't put strict criteria on that. That was pseudoparalysis as determined by the treating consultant, rather than actually putting any strict measures on that. But again, to me, I think has already been said, I'm not sure you would expect any significant increase in function by insertion of this device. We don't know what what the criteria are for pseudoparalysis, but this is not something I could sell for pseudoparalysis.
Thank you.
Yeah, I think that, Steve, just to piggyback on that, I think one of the harder problems, though, when we say that, though, is that your definition of pseudoparalysis may be different than my definition of pseudoparalysis, right? And that's one of the things that we struggle with as shoulder surgeons, is just how do you identify it? How do you know which pseudoparalysis is truly irreversible versus irreversible, which is why we chose the 90-degree mark, because I think by all definitions, we would all agree that anybody with over 90 degrees of elevation would be non-pseudoparalytic. So I think that that's it's difficult to understand how your surgeons may vary between their definitions and who they included in this trial. Can you comment on that at all?
Yeah, no, I mean, I think these were all experienced, fellowship trained shoulder and elbow surgeons, and we left that for them to determine We didn't have any strict criteria. We just didn't want to include these patients in that may skew the results. So if the treating consultant determined they had pseudoparalysis, they were excluded. I think that ensured that we weren't including patients where, I think our results were skewed by, someone whose definition of pseudoparalysis was, anyone less than 30 or 40, as opposed to 90.
Great. We'll move from movement before surgery to movement after surgery. And here I have a question for Nikhil. Did you differentiate the rehabilitation protocol between rotator cuff partial repairs and balloon insertion? And do you fear that early motion could endanger the repair in the case you did a fast rehabilitation protocol for partial repair patients as well?
Yeah, as I said, we didn't differentiate, and we used a conservative rehab protocol as one would use for a partial repair, simply because if we had differentiated, then obviously patients would know which device they got and we would lose blinding. And to your point, the rehab for the partial repair is much more conservative than for a balloon arthroplasty. So we are currently looking at whether an accelerated rehabilitation program is applicable. And I found anecdotally, again, this is non-scientific, that as I started to use this device in patients outside of the trial, that going really quickly with their rehab may not be all that beneficial. They may need a period of 2 or 3 weeks of sling immobilization rather than 3 to 5 days. So it'll be interesting to see the results of that. But we did lean towards the conservative protocol, as you would expect for a rotator cuff procedure.
Thank you. The first and last question before we give the talk to Olaf regards to the postoperative medication. Did you have any postoperative protocol on medication, for example, narcotics or the non-steroid anti-inflammatory drugs, or did you leave the patient free to take the needed medication and note them down to take report on it?
No, we didn't. We kept it pragmatic, whatever the local unit used.
Same, we basically use standard of care protocols for post-op recovery.
Okay.
Okay, great. So, Ofer, ready for your talk?
Okay. Share my screen. First of all, I would like to thank Gregory for inviting me to talk about biases in publications. First of all, I'm not talking about any of these studies we discussed today about the balloon. It's more a general philosophical, provocative thought. Again, I'm not accusing any of the authors that I'm going to quote with dishonesty or anything. I just mentioned things to think about when we read papers or we hear about papers. To start my talk. Okay. So actually, these are my disclosures, and as you can see here, and as any one of us that's got disclosures, have to disclose them before paper. For this publication, actually, I've got no conflict of interest, and I've got really interest in thinking about transparency in publications. So all this started actually, and I think that's what initiated Gregory to invite me, from a comment I mentioned in the SECEC meeting in Dublin, in the BESS session that was on randomized controlled trials evidence in treatment of rotator cuffs. And actually, there are some discussions or presentations of randomized controlled trials led by some UK research institutions. And the authors, some of them in their CVs received many millions of pounds in funding for the institutions, yet when they declared about the study, they declared no conflict of interest. And what actually made me a bit more concerned was the moderator, Cormac Kelly, commented that regarding the 2 balloon studies, that the American one was supported financially by the industry, by Stryker, and therefore possibly biased, whereas the UK study was not biased. but again, not mentioning that it was funded by a government body, by the NIHR. And that's actually a thing, I was thinking about it, and there's a concern about new breed of publications, and not only in orthopedics and not only in medicine, generally, there are publications with agenda. And it's a general phenomenon in our era, in our society, but the news, social media, fake news, as we call them, and agenda-led research, or something that want to make sure that we think about studies or results in certain way. So just to take, for instance, the COVID-19, and there is some concerning trend in medical publications and bias in acceptance of studies during the COVID. So for instance, if you look at the study from the WHO on the left side, this is a study that published recently in Nature, which is a major leading journal, and was led by WHO scientists, and supposedly, in inverted commas, exposed that the real number of deaths due to the COVID virus, and that it was 2 to 3 times more than the official number that was thought. They calculated the expected death, and in which large parts of the world there are no records or not any death data. So how come they could assess it or calculate it? On the other hand, the study on the right was a study from Stanford University, led by a Nobel laureate, by Michael Levy, that showed that even in countries with good death data, the calculated models can provide results that may differ within 20%. And if you change the time frame, this can change even more the excess death from positive to negative. So possibly the excess death from COVID may be much lower than previously calculated. However, this study was not accepted to Nature or Lancet or one of the big journals, but published in Environmental Research. So there another study in October 2021, published by the CDC, the Center for Disease Control, that not wearing masks in children is correlated with higher number of COVID patients. More recent study, a larger study, similar study, has shown the opposite results. But this study was rejected from publication by the CDC. So it seems that there was sort of a publication selection bias here. So this new form of study that has been accepted to leading journals, and all these studies have similar characters. They have serious methodological flaws, and they would have been rejected by editors prior to the COVID pandemic, and during the COVID, everything was accepted. Their conclusions cause fear and are not supported by the fact, but they support certain agenda or regulating body agenda. And the authors, which are related to government bodies or trust and supported by some of these government bodies' funds, they create a large media impact in the newspapers, social media, television, and sometimes even before the paper was published. And they use selective data and a very smart mathematical models that are difficult to check or criticize, and that's a major problem. Now, recently, in the recent years, we have similar phenomenon in the orthopedic arena with orthopedic randomized controlled trials that have been accepted to non-orthopedic leading journals. And again, these studies have similar characters. The RCTs, the randomized controlled trials, are known to medics with drug trials, but are difficult and far from optimal in surgical fields. And we know that not every surgeon operates the same, and different techniques and different, and although you try to standardize everything in surgery, it's really difficult. They have serious methodological flaws, and I believe that these studies would have been really criticized or rejected by orthopedic reviewers and editors, and they published in medical journals. But conclusions that suggest that, usually suggest that operations do not work, are not supported by the facts, but may suggest some saving to the healthcare payers. And the authors are related to universities and trusts supported by government bodies and funds. Again, I'm not accusing them in anything, but again, you have to remember that. And usually these studies create a large media impact. They're published in newspapers, TV, and usually prior to the peer review publication. So I'll take one of these studies first. It is the well-known Ofer randomized clinical trial about the fractures of the proximal humerus. And if we read the conclusions and the relevance, it says among patients with displaced proximal humeral fractures involving the cervical neck, there was no significant difference between surgical treatment compared with non-surgical treatment in patient-reported clinical outcome over 2 years following fracture occurrence. These results do not support the trend of increasing surgery for patients with displaced fracture of the proximal humerus. These are very misleading abstract conclusions and do not represent the paper. So if you look at the methodological concerns, out of 1,250 eligible patients, 1,000 were excluded for various reasons, among them because there were clear indications for surgery. It means that only patients with an unclear indication for surgery were studied. It remains unclear which patient needs surgery or not. The fracture classification thresholds were not clear. There were 66 surgeons, including trainees, performed 109 procedures with a large variation of results. The only surgical procedure was using the locking plate that we know that has got very high complication and reoperation rates. And there's some ethical concerns. The most worrying one is the simplifying, misleading headline in the newspaper, in the journal media of the newspapers. Research news, surgery is not better than a simple sling for displaced fracture of the upper arm. Study finds. And then this is topped up with reference in JAMA, which is, you know, an important medical journal. And the potential damage to patients requiring surgery that being refused or rejected by those who pay for it, this is of great concern. So instead of writing this in the abstract, I think the authors could have written what they found indeed, that in a selected group of patients with proximal humeral fractures and which the indication for surgery based on contemporary practice was unclear, there was no significant difference between surgical treatment with locking plates compared with non-surgical treatment in patient-reported clinical outcome over 2 years. And that these results caution the use of surgery for patients with uncertain indications. Now, the authors claim that there was no disclosure or no other disclosures, but we know that this clinical or research centers get really many millions from government or the National Institute of Health and Care Research, the NIHR, and these may represent a conflict of interest, and this should have been declared, which it didn't. Again, as it concluded that these results do not support the surgery, and these operations cost money, therefore the healthcare payers, whether it's government, NHS, etc., if they adopt the conclusions and not approving these operations, they save a lot of money. and the suffering of the potential damage to the patient requiring surgery but refuse surgery is not in this equation, as well as the late cost of more complex procedures for fracture sequela is not taken into account. If we go to another paper that was recently and caused a lot of this debate and actually conflicts in the literature and in the orthopedic world or shoulder world, is the paper in the Lancet that first of all, the name of the study, SECEC and shoulder arthroscopy work, shows a bit of bias in thought. You know, if you ask yourself, can shoulder arthroscopy work? But again, if you read the interpretation in the conclusion of the abstract, it says that surgical groups had better outcomes for shoulder pain and function compared with non-treatment, but this difference was not clinically important. And more than that, surgical decompression appeared to offer no extra benefit over arthroscopy only. And these findings question the value of this operation for these indications. However, there are some concerns. I mean, again, there were 313 patients out of 740 eligible patients. Why more than half of the patients were excluded? I don't know. I mean, these 313 patients were operated by 38 surgeons. So each surgeon treated about 8 patients. So there are 3 groups. So each surgeon operated arthroscopic decompression in less than 3 patients. And patients with shoulder pain, what was the etiology? Was it all impingement, or there was some other causes for shoulder pain? It wasn't really clear. And obviously, if you do an arthroscopic decompression for a frozen shoulder or osteoarthritis, this will not benefit the patient. However, in the paper itself, the authors write that one conclusion from our study is that both arthroscopic subacromial decompression and arthroscopy only are effective and regardless of mechanism, and could be used as treatment strategy for patients with subacromial impingement. And although statistically better, and they are statistically better than no treatment, does not provide patients with clinically important benefit. And this is more an opinion rather than the result. So actually taking the results and changing it into an opinion. Again, the authors we declare no competing interest. Again, we know that the government actually support these institutions with many millions every year. And I'm not claiming anything, but I'm saying that this may represent a conflict of interest and should be declared. And we know that as a consequence, and all the UK guys can tell you that as a consequence of this study, the NHS in the UK does not approve arthroscopic decompressions, or you have to jump many hoops in order to approve surgery for such a patient. And this gives a huge saving to the NHS and the government in the expense of the suffering of the patients. So as authors and readers, I think we always should keep our integrity. We should read the papers critically. We should declare all potential conflict of interest, whether it's industry, government, or whatever. We should keep transparency and honesty. We should avoid bias as much as possible. And the abstract and the conclusions of the study should represent the results and not suggest an opinion or a specific agenda. Thank you very much.
Thank you, Ofer. I think this is a quite enlightening talk about bias in general, and COVID went hand in hand with fake news and amplification, of course, is one thing, but also with a lot of realization about healthcare restrictions that need to be done by the government. And I think this is another trend to push towards cost savings and trying to prove that a procedure does not work or is not efficient. So of course, there's also a kind of indirect bias here. And at the end of the day, it's our patients which will suffer from this if we are not a little critical about these facts that you pointed out. So I heard you, in fact, at the last SECEC conference, starting an interesting discussion. I thought it was important to amplify it here in this SECEC webinar. Thank you.
Thank you.
So is there any, I don't know, any government pressure to spend less or operate less in the US, for instance? Nikhil, do you feel this kind of pressure as well? Because in Europe, we do feel it, at least in Switzerland as well, where I'm from.
Yeah, absolutely. I mean, we've seen the same type of covering decisions that Ofer was referring to. You know, subacromial decompression is no longer a covered procedure. It's an add-on procedure for shoulder arthroscopy. It's not paid by most insurances. There was a randomized trial very similar to what was discussed in meniscectomy that has led to some of the insurance companies rendering meniscectomy to a experimental type procedure. And so there's no question there's downward pressure on all of the procedures that we do. And in addition, there's very little incentive to add new technology, such as the balloon, unless the evidence is extremely robust, which makes it expensive and challenging to try to demonstrate value or to develop new technology that may help our patients. So I think it's something that we struggle with around the world.
Coming back to subacromial balloons, Ofer, do you use any subacromial balloons in your practice?
I didn't use much. I've got very few patients that I think that are actually good candidates for that. And I think that there is a place for this balloon, but it's a narrow indication. I mean, Nick and Steve actually alluded to that. Definitely, if there's any arthritis or stiffness, you shouldn't use it. And in my view, it's sort of for patients that you don't want to do any other operation, you want to do a very simple short operation because of any comorbidities or whatever, and they are painful rather than they don't really care too much about function, but the pain. It's in a way it's expensive painkiller, but in order to break the vicious circle of pain and to allow them to do the deltoid rehabilitation to get the good function, I think that's how it works. It's actually break the vicious circle of pain and allow them to do the deltoid rehabilitation protocol.
An injection of cortisone wouldn't do the same effect for you?
Possibly, yes, and this is my first line is injection. I will do injection. I would say that's why the balloon, in my view, the indications of the balloon are very, very limited. And I would say that I have another concern about the balloon. I have a concern that it will be used by surgeons instead of doing a repair to get the optimal result to a patient. They will put the balloon in and they will actually sacrifice good result for easy operation. And in my experience, I had to remove 2 balloons that were put by surgeons that decided that it's irreparable cuff tear and did a balloon, and it was a mistake. It was a traumatic tear that could be repaired, but they gave a balloon to a young patient. Again, that's a risk with any technique. It's not the balloon that's a problem, it's the indication of the surgeon.
Has the panel any questions or comments about Ofer Levy's talk, or want to add something to it?
Yeah, I would just make a comment that, you know, first of all, I'd commend Andy and his group for the work that they've done. And I think the reality is that there's not an argument about whether we're right or they're right or whose study was appropriate. I really do think it comes down to what we've been talking about, which is, you know, finding that group that it's beneficial for. And our indications were extremely strict in terms of exactly what Ofer referred to. It's an older patient, low demand, they can raise their arm. They're probably too functional for a reverse arthroplasty. They don't have arthritis, but they just want to sleep at night. And that was the very kind of sweet spot group that we've identified as being beneficial. Now, I consider myself a busy shoulder surgeon. I do probably 500 to 600 shoulder procedures a year. If I use 15 balloons a year, that's a lot. I mean, this is a very, very select population that it's indicated for. And we've seen the same issues in the United States with the introduction of a balloon, that as the indications have creeped and patients say, well, I'm going to try it for, or excuse me, surgeons say, I'm going to try it for this, or I'm going to try it for that, or, you know, they expand the indications. We do see the failures that are being discussed or that maybe were identified in the European trial. So I think both trials were well designed and well done, but I really do believe that we probably had a much narrower population than maybe they explored, and that's why we saw a difference in the results.
Thanks for this comment. So I think, yeah, I salute both trials. It's really great publications. And I think you are both exploring different groups of patients, and we have to keep looking for these niche indications for treatment, and this should be done for other procedures, of course. So there's definitely a need to keep going with these high quality evidence studies. So I think now it's time for a bit of discussion. We have some questions from the panel, and Davide Cucchi will read them out loud to us, and we can answer it and have a bit of a debate.
Exactly. We have a couple of questions. I tried to group them a bit in 4 main big topics. The first one is regarding the radiological results. Nikhil, you mentioned you conducted an MRI study on your patient, and Andy and Steve in your publication, it is mentioned as MRI study is ongoing. Can you tell us a bit about how do these balloons look like after 1 or 2 years if we do an MRI on it? Nikhil.
Yeah, so sorry, we looked at it at 2 different time points. We have a publication that's submitted to Arthroscopy that should be out in the next 3 months or so, looking at the early time frame. And really it was designed to help identify what does the balloon look like at an early time frame, and how do you define whether the balloon is located or not. We found that the vast majority of the balloons were inflated and located properly at the 12-week time frame. And we did see a subtle difference in terms of patients having a slower recovery if the balloon was identified as being quote unquote displaced at the time of that initial MRI scan. Now, the hard part, as we know, is that the balloon is mobile. And when you take a static picture, it can be difficult to know, has it been in that place for an extended period of time? Does it move? Or, what does it look like day to day with movement? What I have found is that I do tend to oversize the balloon a little bit, and I really limit my bursectomy because I do think there's a risk of migration, particularly in the anterior gutter. And I think that's part of the reason why, if you have a subscapularis tear, that in addition to the functional loss, it may not provide containment of the balloon within the subacromial space. When we looked at it in a year, we found no device remnants, and we really could not see any untoward effects in terms of progression of muscle atrophy or arthritis or other changes that may be reflective of the biodegradable process that were different than the reparative group. So by a year, the balloon is pretty absent. I've now done 2 revisions on balloons for reverse shoulder arthroplasties at 1 year or more, and they've been very similar to standard reverse replacements in that I did not see a significant sequelae of the balloon resorption process. Now, that's a small n comparative number, but that's just been my anecdotal experience.
Thank you. Steve, Andy, what is your experience with MRI after balloon implantation?
Yeah, thanks. So we did an MRI study, although we were really hampered by COVID. So just as the patients were coming up for their follow-up time was when the lockdowns all happened, and patients just didn't want to come to follow up. So we scanned 17, and what we were trying to do was a sort of biomechanical study. So we had this method of activating deltoid in the scanner by using a thoroughband that they pushed out against by 5 centimeters. And in truth, I mean, I think we tended to scan at 6 months, and we had, very similar to what Dr. Verma has described. Many of the balloons by that point were disintegrating. The few that we scanned a bit later had disintegrated without any obvious negative effects. And we didn't really see a biomechanical effect of the balloon or not, but in truth, it was an attempt at a new novel way of stressing that, of activating the deltoid in large rotator cuff tears to see if we can get some proximal migration. So we can't say whether our method was sensitive enough yet. But yeah, in terms of does it disintegrate? Yes, I think that's right. Did we see any concerns on those scans? No, I don't think we did. So yeah, support what Dr. Verma has just said about that.
Thank you. The second question.
One comment I'd just add
Yeah.
to this, just as in a general sense, is that I think it's a shame these two studies were done now rather than 10 years ago, given that the balloon's been out for 13, because we're now really trying to define our subgroups when it's had 30,000 of them inserted. And I think it would have been far more beneficial for patients if we were doing this in sort of 2013 rather than 2023.
Thank you. The second question I get from the audience regards unsatisfactory outcomes. And so I would ask you this question: if you would get a patient who comes back to you and tells he has persistent pain, loss of function, so what would you tell him? Why did the balloon fail? What is the sentence you use to tell the patient the balloon has failed? There is a reason behind this, and what do you do with these failures?
So I mean, my own thoughts on how it works is it gives you a window of opportunity to sort of rehab the patient more effectively. So what you're looking for is a period of pain benefit for 3 months, 4 months, so that you can you've then got a sort of better compensated cuff tear, got some humeral head depression, and that allows the therapist to get their deltoid working. The problem is, there's no doubt there's a subgroup where they don't get that pain relief. And I think if they don't get that pain relief, then you've lost your window of opportunity to rehab them. And that's my experience of why they fail. And then you're really into different groups. And I think you know pretty quickly, I think you know whether the balloon's going to be effective within the first 3 months. And if they haven't got that pain relief, then they're not going to get it.
And the next,
I would completely agree with that statement. I mean, the results that we saw or see that are positive, it's pretty remarkable how quickly they feel the pain relief and are able to reestablish elevation. I think in that situation, there's 3 possibilities. One is you pick the wrong patient. So stretching the indication certainly is going to increase your risk of failure. Maybe they have a little bit of arthritis, their subscap is dysfunctional, stiffness, those types of things. Secondly is there are a small group that have device displacement early on. And in those patients, I do think we can see early failures. Third is there is a small subgroup that gets an inflammatory reaction around 12 to 16 weeks as the balloon is absorbing. We've been very successful with managing those with an injection at that time. I have not had to remove the balloon when that happens, and the vast majority of those will go on to recover uneventfully. And then finally, just like any rotator cuff procedure, there's a group of patients that just aren't going to be successful. And in those patients, I think that in large part, given their age and the fact that you're now moving to a revision procedure, we know that reverse arthroplasty works very well and can be a good bailout procedure. What I like about the balloon is that in my experience, when you're doing reverse arthroplasty for failed SCR, failed tendon transfer, failed massive repair, it really is those procedures really do result in a compromise in the outcome following the secondary reverse. There's no such thing as we've not burned a bridge. In my experience, those patients have probably about a 15-point difference on their outcome scores compared to a native reverse for cuff tear arthropathy, or even cuff tear dysfunction in the absence of arthropathy. My anecdotal experience with the balloon is that that's not the case, but it will be really interesting to start to look at some of these failures of the balloon to determine, does it have the same negative effect that larger procedures have on subsequent conversion to reverse replacement?
It's a very interesting point, Nikhil, because there was a study that stated that the SER may burn bridges towards the success of a reverse shoulder arthroplasty. First, you shared the thoughts, and why wouldn't it be the case with the balloon? And second, how do you compare actually the results of balloons and SER?
Nikhil, you are muted.
Sorry, I'm muted. I don't think that the compromise of the secondary procedure is the same. And I'm going to, again, admit that I don't have any data to support this, and we need data in the future. But the reality is when you go back on a SCR or a massive rotator cuff tear, you have extensive adhesions within the subacromial space, you have retained implants. They generally have lost range of motion because they're stiff. And they do marginally well, but generally we just don't see the same range of motion recovery as we do with primary arthroplasty. And I think the nice thing about the balloon, as you saw from the data, is it's very range of motion friendly. And so if you have a patient that has good motion that's still painful and we don't see any remnants of the balloon left behind, then I think that that's the logical explanation as to why we may see better results following revision to reverse. Now we're going to have to look at that to determine whether that's true or not. But I absolutely do not believe that to say that a massive repair or an SCR or a tendon transfer that fails to that matter is a burn no bridges procedure. I think it definitely impacts the results of the secondary reverse replacement.
I know that Udi Atun from Israel actually got a series of patients that he did a reverse shoulder following a failed balloon, and his finding was that you are not burning any bridges. So I think his paper is due to be published soon, but that's what his findings are. Great.
I have another question here from the public. It regards the possibility to use the balloon as an augmentation. Do you have any experience with the combination of the balloon over a repaired rotator cuff? So you do the rotator cuff repair and then you put the balloon on to protect it, or there is just, I think, a technical report on it, on a latissimus dorsi transfer.
I don't have any direct experience. I know that Laurent Lafosse will often talk about his anecdotal experience in doing that. It certainly is one of the things we're interested in studying in the United States. I guess for me, fundamentally, the question is, what are we trying to achieve when we do that, right? Because there's two different outcomes with rotator cuff repair. One is the clinical benefit and one is structural integrity. And we know that those two outcomes are not necessarily linked. You can get good clinical outcomes without structural integrity. So if we're trying to improve the clinical outcomes for patients, I'm not sure that I believe that the balloon on top of a repair is going to do that. I think if you're making the argument that maybe the balloon protects the repair, acts as some form of an internal splint, and may improve the structural integrity, I don't know whether that would be true or not, but that's the only potential benefit that I see of doing that. And I think it's going to be a long run for a short slide to help us to identify whether that's the case or not. What I do think is that, you know, in the study, we were very, very strict about identifying these very large tears that were mechanically irreparable. I think that there's a secondary group of tears that we have the techniques now to be able to repair, but they're still, quote unquote, biologically irreparable with failure rates of 50, 60, 70, 90% in some studies. In my opinion, that may be an area where we have some traction to try to increase utilization. But again, we just don't have the data, as was already said, to define exactly where it may benefit in those patient groups.
Great. I see Dr. Verma is up and warming up for his next surgery. So maybe we should jump to the conclusions, Davide.
Yes, I'll do it. I'll just share a couple of slides to it. First of all, thank you to all the speakers for having this nice talk about subacromial balloons and sharing some ideas, some thoughts on them and their experience in the design of the clinical studies. What's interesting about the balloons is that actually, as we already stated, we have an experience about 30,000 balloons implanted since 2010, since the market approval. But the quality of the studies which were generated over these years remained just on level 5, level 4, without any significant increase till the last year, in which we had a contribution of 2 level 1 studies. And also the number of patients which were operated, which were presented in these studies was quite limited, and the contribution of Nikhil, of Andy, of Steve was a great increase, not only in the reported results of these techniques, but also in the quality of the study. We could hear about 2 very well designed studies, which some important difference. the group of Nikhil, the group of Andy and Steve, they did not perform the same study. This is very important. It's not just comparing apples and apples, but up to some aspects is comparing apples with pears. So the results are different because they reflect different patient enrollment and different operative choices. But I think the authors could show us in this talk the role which a balloon can play and the reason to use it or not to use it, and in which patient we can consider this technique. I think we can conclude then this webinar, thanking all the speakers, Andy, Steve, Nikhil, or Ofer, for their time and their great talks. Thanking Sylvie Noel for the organization and SECEC for the support. You are all warmly welcome to have a look at the SECEC website to follow the next events. You can find them on the QR code, the patronage event from SECEC, and then the live meetings in Rome in September and in Munich next year, again in September, for the official meetings of the society. From my side, thank you. Greg, if you want also to conclude.
Well, thanks a lot for your time, and keep up these great studies. I think we have 2 studies showing when to use a balloon and when to not use a balloon. So they're not contradicting studies, they're just looking at different things. And this is, I think, the main message of this webinar. I don't know if the panel has anything to add, or else I think we can definitely conclude to this successful webinar. Thank you very much for your participation, and have a great evening.
Thank you.
Thank you very much.
Thank you.
Thank you to all. Thank you, Greg. Thank you,
very
David.
much.